Welcome back. I'm excited to welcome our first listening session. Josh and the PCDT helped us level set with background information and our goals for this public meeting. Now we've invited 3 outside experts to give short presentations on their vision for developing successful population-based total cost of care models based on their experience. Their full biographies are on the ASPE PTAC website. Their slides will be posted there after the public meeting as well. After all 3 have presented, our committee members will have plenty of time to ask questions. Presenting first, we have Dr. Mark Miller, who is the Executive Vice President of Healthcare at Arnold Ventures. Please begin, Mark.
Okay, thank you for having me here. We can move to the next slide. I don't have any conflicts of or financial conflicts of interest, and the opinions I express here are my own, but in this particular instance, the opinions are also reflect the organization. We can go to the next slide and just give you a little sense of who we are. So Arnold Ventures is a philanthropy. We give out money for research, develop policy, technical assistance, communication, education, that type of thing. My particular portfolio is focused on containing healthcare expenditures, and it's aimed at the 3 parties that end up paying for healthcare, which are employers, taxpayers, and then households. If we could go, well, before we go to the next slide, I have portfolios that address issues in the commercial sector, price issues in the commercial sector, drug prices, incentives for providers and Medicare sustainability. Is also care for complex populations. And in this context, a way to think about the last one is care for those beneficiaries who are dually eligible for Medicare and Medicaid. We'll go to the next slide. In the portfolio that is most relevant to the conversation here, we're interested in increasing the share of spending and enrollees in population-based models. We want to hold the providers, we want to give the providers a financial incentive to provide high quality care, but to also contain costs. And I also have research running trying to identify low value care so that that kind of information can be put in front of providers to help them to perform inside, capitated systems, accountable care organizations and the like. Another element of our strategy here is also to reduce fee-for-service payments for low-value care and generally make fee-for-service a less profitable environment to encourage providers to move into more population-based total cost of care models. And then finally, we also think an element of this is to align the consumer or the beneficiary's incentive in this instance so that they also are participatory in the incentives of the system, both quality and containing cost. We'll go to the next slide. And so then I'll just walk through a set of principles here that guides the research and policy that we have been driving towards. As I said, we fund a tremendous amount of research, and then we also talk to federal policymakers, both on the legislative side and on the executive side. So our work emphasizes a shift to population-based payment models. We have less interest in pursuing the more of the episode-based types of models. We're concerned that going to those types of models is just fragmenting fee-for-service in a different form, and we think that the best incentive structure is to have a population-based models. As I said, I think models that are more targeted or, in my opinion, more fragmented, dilute the incentives to contain costs and to improve quality. We do think that there is a role for some of those kinds of elements in a population-based model, but it should be relatively limited. And that the emphasis should be on improving quality and controlling costs at the population level. We think there should be a relatively limited set of tracks for people to get into the population-based models. We believe that the CMMI developed a lot of different models, and we think that that should be streamlined and directed towards population-based models. But we also think there should be tracks to help and encourage different kinds of providers and organizations to get into those models, lower risk models. And when you have lower risk models, you also have lower reward, but ways to kind of ramp providers and organizations in, but ultimately driving towards a two-sided risk model. We also think that there are other ways to strengthen and simplify incentives for participation in models. These are things like, financial support, for an organization or a set of providers to develop their systems, technical assistance. We also think there are some instances in which you may want to think about mandatory models. And then, as I said, and that's less about the conversation here, we would also make fee-for-service, continue to make fee-for-service a less comfortable place to be for providers. And that could involve things like greater differentiation in what you get paid in the fee-for-service setting versus entering a population-based model, and also things like allowing much greater flexibility when you go into a provider-based model, such as using telemedicine and those types of services. We'll go to the next slide. We also think that there are both immediate improvements to the benchmarks that need to be undertaken here. I will leave this conversation to Mike and to Mike, but this is things like addressing the ratchet effect, the rural issues, regional adjustments. So we think there are improvements there. But ultimately, I like the idea, and again, I think the Mikes are responsible for a lot of this, is the notion of moving to more of an administrative benchmark that is a lot more predictable and stable. Okay. And I also think that in moving to that, you would have to take steps to assure that the Medicare program gets its savings as part of that. And I also think an administrative baseline administrative benchmark would allow you to adjust to achieve certain policy objectives, like if there were issues around equity and that type of those types of issues. I think risk adjustment needs to be improved. This is true of both if you're going to move to more of a capitated two-sided risk arrangement in the accountable care organization models, but also for managed care plans. And I think part of the changes in the risk model should involve moving to factors that are less gameable and in order to limit profits from coding. And the model might ultimately have fewer factors that are less subject to gaming and depend more on reinsurance as a way to address variation in risk across different models. Finally, I think that we need to improve how we pay primary care, even outside of the accountable care models. I would have the fee schedule not pay primary care, or at least a good portion of primary care, on a service-by-service basis, and instead pay more on a per-member, per-month basis, and would also try and incorporate those kinds of thoughts into total cost of care model. I think that the primary care providers should probably have a greater role, should have a greater role in steering patients through through the care that they need. And I think paying more on a per member per month basis, or not paying on a service by service basis, is a better way to reimburse primary care. With that, I'll stop, and that'll be it. Thank you.
Thank you, Mark. We're saving all questions for later. So now we have Dr. Michael McWilliams, the Warren Alpert Foundation Professor of Healthcare Policy, who joins us from Harvard Medical School. Please go ahead.
Thanks very much. Really a pleasure to join you today, and thanks for inviting me to be part of this meeting. You can just go ahead and advance to the next slide. Just wanted to mention my disclosures. No real relevant financial conflicts. Did want to point out, however, that I am serve as a senior advisor to CMMI. I am here in my Harvard capacity today, so nothing I say today should be construed as representing the views of CMMI or CMS. If you could then move to the next one. Okay, just taking a step back and thinking about what we can and can't achieve through a population-based payment model, I think there are sort of more realistic and less realistic expectations. In terms of the more realistic category, clearly we can control spending growth, discourage overuse, and smooth revenue during demand shocks such as pandemics. And we can also give providers more flexibility to select the right services for patients. So with revenue decoupled from service selection, getting rid of those interfering fee-for-service incentives, providers are then freer to choose the right service for their patients. So as a PCP, for example, I don't have to do 120 office visits a week to cover my practice expenses and salary if that's not what serves my patients best. I tend to think of this flexibility as sort of a precondition for care delivery transformation. In the less realistic category, I think is first the notion that these models make prevention or improving health profitable. There's a fair amount of magical thinking out there that simply by putting spending under a budget, we perfectly align the financial incentives in our system with the production of better health. And while it's certainly true that healthier populations need less care, making populations healthier is costly. The number needed to treat is often high, and preventive efforts can induce utilization. So the savings from prevention generally constitute partial offsets at best. There is similarly overzealous thinking, I think, around pay for performance. Quality is just not nearly as contractable through the payment system as the emphasis in policy would suggest. The evidence on pay for performance is not encouraging. It's very hard to establish strong incentives to improve quality because quality is such a complex, multidimensional construct, and a lot can go wrong, including wasteful responses like gaming or teaching to the test, diverting resources away from harder to measure but important aspects of care, or exacerbating disparities because of inadequate risk adjustment. But I think it's also important to note that it's okay that we can't contract directly for quality very well. We have lots of other reasons and ways to improve quality and make patients healthy. We just shouldn't sort of distract ourselves by thinking that everything can be programmed with payment incentives. Quality will always be largely determined by the intrinsic motivation of providers and extrinsic competitive pressures to attract patients and clinicians. That is something I think we not only have to acknowledge when thinking about these payment models, but also actually embrace as we think about how to improve quality. So I generally see the total cost of care or the population-based payment component of ACO models, for example, as far more important and promising than the P4P component. On the quality front, with the flexibility in place from that population-based payment, I tend to think that we should be spending more time and effort identifying changes in delivery that work. I refer to this as a shift from seeking successful measures to seeking measurable success. If we can go to the next slide. Briefly, and this is attempting to cover a lot of ground here, the evidence on ACOs. Much of what we know is from the first 4 years or so of the ACO programs because rigorous evaluation has just become harder and harder in recent years. In terms of savings, there has clearly been behavioral change that has lowered spending. That is unambiguous, but the savings have also been unambiguously small. However, it's really hard to interpret that because the incentives in these models have been very weak. So ACOs have never really had a strong incentive to save. And we have seen larger savings where incentives are stronger, and I'm happy to go into more detail about that pattern. But the key point is that the pattern of savings suggests that if we strengthen incentives, we could save more. The savings seem to be driven more by a story of waste reduction than a story of integration, coordination, and prevention. Happy to talk about that more as well. In terms of selection, there has been minimal patient-level risk selection, but ever since benchmarks started to converge from an ACO's own history to a regional rate, which is necessary at some point, we've seen pretty dramatic selective participation at the ACO and tax ID participant level, favoring those with already low spending. That means that in recent years, the savings have been overstated by program comparisons of spending with benchmarks, and the resulting subsidies have probably negated much, if not all, of the true savings. In terms of quality, the evidence is limited, in part because of data constraints. Certainly no evidence of quality getting worse, but improvements have been fairly small and scattered. Patient experiences has been one bright spot. We've seen improvement in some domains there, but it's not clearly attributable to the pay-for-performance incentives. For example, our team found that improved overall care ratings was entirely concentrated among high-risk patients, and that suggests a potential effect of high-risk case management, which has probably been more motivated by the total cost of care component than the pay-for-performance component. Next slide, please. Okay, so how can we design these models better? A lot to talk about here, and for a more detailed discussion, I'd refer you to this white paper I authored with Alice Chen and Michael Chernew. This was supported by Arnold Ventures and published by the USC Brookings Schaefer Initiative for Health Policy. Very briefly, first, agree with Mark entirely about the need for a parsimonious multi-track structure that accommodates different types of providers, and that would include a low-risk track for smaller organizations that provide less of the spectrum of care. Those organizations don't need as much, if any, downside risk to have strong incentives to lower spending. A low-risk track also helps promote entry and competition. The key point here is that the same risk contract, the same terms, can establish vastly different incentives depending on the type of organization, because the incentives are stronger to reduce care provided by other providers. In terms of downside risk, I think here the upsides tend to get overstated. The benefits really depend on participation incentives. When a model is voluntary and the fee-for-service alternative is not too bad, downside risk really just discourages participation. If you think about it, basically, if an ACO faces losses, it'll exit a voluntary model, so it is never really exposed to the downside risk anyway, so its incentives are really not that strengthened by it. Making the population-based payment fully prospective, meaning all these models have a prospective element, but by this I mean sort of upfront payments in advance. That's a feature that some providers or conveners desire. Can certainly have some behavioral effects, for example, due to loss aversion. It may also offer some advantages in terms of cash flow, but it's really not crucial to establishing incentives. And a fee-for-service chassis with reconciliation does offer some advantages in terms of transaction costs. And I think Mike Chernew is going to talk more about this. Risk adjustment. So what I'd like to stress here is that traditionally the emphasis in risk adjustment has been predictive accuracy or model fit. But we really need to trade off predictive accuracy to support the broader goals of the payment system. For example, spending for historically marginalized populations tends to be similar or lower than for other populations. So if we want to reallocate resources to providers serving those populations, I would argue that we do, then we don't necessarily want to add indicators of those groups to the risk adjustment model. That could make the model more predictive and set payment closer to current spending for those groups, more accurate, but that's not what we want. We want to set payment above current spending for those groups. In some cases, we can do that simply by omitting indicators from the model, and in other cases by taking additional steps to set payment above what's predicted by the model, as was done in the ACO REACH model. Similarly, we'll need to do some things to the risk adjustment system to mitigate coding incentives. That might compromise fit or predictive accuracy, but it's a good trade-off to make. Also agree with Mark about the importance of primary care capitation payments within a total cost of care model as a way to both dial up primary care spending and give primary care providers more flexibility and resources to leverage primary care in a way that can reduce waste and improve quality. And then last, but certainly not least, is the importance of benchmarks. To date, benchmarks have been set according to observed or realized fee-for-service spending. You can think of that as sort of an internal benchmark. That creates various ratchet effects that Mark mentioned. Those weaken ACO incentives to participate and save. There are ACO-specific ratchets in which an ACO's own savings behavior pulls down its benchmark, so it never has an incentive to save. That happens through the regional adjustments and rebasing between contract periods. And there's a program-wide ratchet effect whereby ACO's collective savings drag down benchmarks by slowing national or regional spending growth. So if benchmarks are set at a spending average, the realized spending average, by definition, about half of ACOs will always have spending above their benchmarks. This collective ratchet also means that as ACOs save, or they're not really given the room to innovate off the fee schedule, which is something that we want providers to be able to do in these models. If they do that, then their benchmarks fall. So in the white paper, we advocate for decoupling benchmarks from observed spending, making them external or so-called administratively set benchmarks. In the next few slides, and maybe if you could just sort of click through the animation here to let it wash over those in attendance. I think I'm probably almost out of time, so I can come back to these if you want, but perhaps just seeing this animation can sort of help let this concept sink in. And then I just have a few comments on group versus clinician level incentives, and then I'll stop. All right, so if you could pause here. Given the physician focus of PTAC, I just wanted to touch on some theory about group level versus clinician level incentives. The purpose of contracting with groups is to pool risk and to encourage organizations to do what clinicians cannot, such as organizing care practices, making joint decisions about capacity, and managing the workforce professionals. In general, devolving risk from the group to the clinician level based on the clinician's own performance defeats that purpose. And alternatively, sharing risk with clinicians based on their collective performance also doesn't affect clinician incentives much because a free rider problem emerges. So I have limited incentive to improve my own performance if my reward is determined largely by the performance of others. Often organizations will nevertheless do that or transmit very nominal risk to clinicians as sort of a signal of organizational priorities. But to be clear, neither of those really changes clinician incentives much. So in the end, beyond shifting internal compensation from fee-for-service towards salary, changing clinician behavior is really largely a matter of non-financial incentives. It's a management challenge. Next slide, please. Have some thoughts here about ACOs and episode-based payment models, but why don't we skip ahead because I think I'm out of time. And then just wanted to note at the end here that there have been very promising recent developments in the ACO REACH model. I think the health equity benchmark adjustments really is a paradigm shift in Medicare payment policy. Also, a number of changes proposed in the physician fee schedule proposed rule for the shared savings program that are quite important, but obviously some areas that we still need to work on listed here. So thanks very much and look forward to further discussion.
Thank you very much, Michael. Next, we have Dr. Mike Chernew, who is the Leonard D. Schaefer Professor of Healthcare Policy and Director of the Healthcare Markets and Regulation Lab at Harvard Medical School. Mike, please begin.
Thank you so much, and thanks to you all for having me. It's always nice to talk with you. I have no financial incentives, and I am, like Michael, speaking in my role as Harvard professor, not as part of any organization that I am a member of, including, most importantly, MedPAC. I am not speaking on behalf of MedPAC. I am speaking on behalf of Michael. I want to talk about an issue that Michael was alluding to. I don't think it gets enough attention in the grand discussion of payment reform, and that is this notion that the healthcare system operates at many levels. So there's a source of funds, say it could be Medicare, the employer, or individual premiums. Those funds are often funneled through a carrier, say an MA plan or maybe a convener ACO. Those funds get funneled to a health system, say Partners. They get funneled to a medical group or sometimes an individual hospital within the system. So there, for example, is the Mount Auburn Physicians Association is part of a bigger system. And then that gets funneled down to an individual provider. It could be a doctor or some other clinician. Some of these steps can be skipped, and the incentives can vary by step. So let me expand on these 2 bullet points for a second. Next slide. So, for example, in a ACO, and I think this is really some of the original motivation for ACOs, the goal was to skip past the insurance carrier. And to some extent, the original vision was to skip past the conveners and go directly to the delivery system. This could be sort of an Elliott Fisher version of an HMO, where you go to a hospital system and the money goes straight from the payer, say Medicare, to the hospital system and everything that's underneath it. In a fee-for-service world, the money goes straight from the payer, say Medicare, to a medical group, sometimes an individual provider if it's a solo practitioner. So you can skip steps. Different arrangements work differently. Next slide. In the incentives, and I think this is important, the incentives can vary by step. So you can have a population-based payment model going from Medicare to, say, an insurance carrier or a convener ACO. That could be population-based. Those organizations can in turn pay the delivery system in a fee-for-service way. And there's a whole bazillion different ways that fee-for-service can play out. It could be using a fee-for-service fee schedule. You can get payments by RVUs, a bunch of other things. The money can flow through to a medical group. They can be given a budget with a bonus, for example, which could have some fee-for-service components to it. They can be bonused for quality. They can be bonused for generating RVUs. They can be bonused for a whole series of things. And then, of course, the incentives can be paid differently to the provider. And again, they can be paid a salary. Of course, they could also be paid a salary with a bonus or some version of fee for service. So it would take me way more time than I have and way more creativity than I have to be able to sketch out all of the different versions of compensation that occur at these different steps in the system. But it's important to understand that what you think might be going on at the source of funds level may be very different than what happens as you move through the system. And for example, if the healthcare system is getting paid fee for service, when they decide how they're going to compensate, say, individual medical groups within there, they're much more likely to bonus things that are consistent with the way they are paid. So in any case, hopefully that will lay out some thoughts for question, but let's go to the next slide. Michael again alluded to the non-financial incentives can vary dramatically by step. In the fee-for-service system, typically we think that's where we use a lot of patient cost sharing. Of course, you get a patient cost sharing in MA, you can have patient cost sharing in ACOs, but in fee-for-service, that's really the main way in which you control utilization. And a lot of the fee-for-service incentives, say in Medicare, can be undone by supplemental coverage. So you can put in place incentives and it can be undone because people buy supplemental coverage. By the way, I'm not going to talk a lot about prescription drugs, but this happens all the time in prescription drugs. You put in sort of formulary restrictions. The drug companies put in place different copay assistance programs. Then the employers put in place various copay accumulator programs to kind of try and undo that. There's a constant back and forth in fee for service about how to both incent patients to use less and then to dampen those incentives. In ACOs, there's a ton of managerial incentives, education, information, financial bonuses, administrative hurdles, investments in care infrastructure. MA can use many of those same tools. They also can use network design. Convener ACOs can also do things with network design, prior auth, benefit design, and the MA plans themselves can put in place alternative payment models as it moves down to the delivery system. So you could have Medicare paying a Medicare Advantage plan, a population-based payment model. The Medicare Advantage plan can take that population-based model, change it however they want, and transfer those incentives to the delivery system as context, as they see fit in the context. Next slide. So there's a lot of attention and there's been a lot of discussion around the cash flow, who gets the money directly from, say, the organization, the payer at the top of the step. So let me make a general point that the incentives refer to how profits are affected by utilization. So basically, if I do an extra MRI, do I make more money or less money? They are typically holistic. And what I mean by that is it doesn't matter what the incentives are on a particular day. What matters is when you look back, say, over a course of time, how much money do you have? So, for example, in a simple setting, fee-for-service with a year-end reconciliation will have incentives similar to capitation. So actually, I should say an ACO paying fee-for-service during the year with a year-end reconciliation will have incentives similar to capitation, where you pay the money up front, depending on the design, how fee-for-service profits and penalties are offset. So, for example, if you are in an ACO that has strong symmetric two-sided risk, and you're paid fee-for-service over the course of the year, but there's reconciliation at the end, the organization that does the MRI will lose any fee-for-service profits induced by the fee-for-service payment during the course of the year by a penalty at the end of the year. And again, the details of the model matter, but basically don't get distracted by the fee-for-service incentives that were happening during the year. What matters is when you think back at the end of the year, what penalty are you going to pay or what bonus are you going to lose or get is what matters. So I think what has to happen in these ACO models is you need the cash flows on a daily basis to just facilitate operation. It avoids the need for the ACOs to have complex contracting across a whole bunch of different unaffiliated providers. You can simply pay fee for service and assign the patients, align the patients, attribute the patients, whichever word you prefer, to the ACO, and that ACO doesn't necessarily have to contract with all the other organizations. They just become responsible in varying ways. They have fewer tools, in my opinion, than an MA plan, but their incentives are the same, and depending on how they do that contracting, the fact that fee-for-service was going on underneath is much less relevant. So I think the concern that many people have that everything is built on a fee-for-service chassis is really a bit of a red herring. I think you have to think through in each model what the incentives are to the organization. It's sort of at the end of the whatever performance period you're concerned about. Hopefully that was clear. If not, we'll have some time to chat about it. Next slide. So the other thing that I think is important to understand here is that all of these organizations, what matters, there's a relationship between sort of the higher levels of the steps and the lower levels of the step, and that relationship can be one that I would characterize by either policing or partnering. So MA plans control the beneficiaries. You sign up with an MA plan, you're an MA plan enrollee, and so when the MA plans build their networks, they have some leverage over providers. If the providers don't sign up or agree to various utilization review procedures or whatever it is, the MA plans can cut the providers out of the network, and that leverage enables them to use some of the tools from the previous slide. ACOs, they're either providers, so the money goes directly to the hospital, or they have to recruit providers, like in the case of a convener ACO. So if you're a convener ACO, you don't own the patients. You need to recruit the providers in order to get your patients. And that gives the providers more leverage over the convening ACO. So their ability to do things that the providers might not like is much more limited in the ACO world. In both cases, the MA plans or the ACOs, convening ACOs, they can partner more or less with the underlying organizations that are delivering care, but the leverage matters and it differs a little bit in the model. And that's much less related to the cash flow issues, in my opinion, and much more related to who controls the patient and what control over those patients that gives the organization. So the cash flow from payer to provider to convener, or from payer to convener to provider is really not central to the incentives, in my view. I'm not going to argue it doesn't matter, but I just don't think it's central. So if you wanted to pay the providers directly and have them hire a convener, an organization like, say, Aledade, which is now an ACO, to help provide information support and manage their patients, that's fine. The money goes to the provider and the provider pays Aledade. Or you could set up a contract where the money goes to Aledade and they just agree to pay the provider. In either case, the provider controls the patients, and therefore Aledade has to come to the table recognizing that. So that's sort of my summary of this, and the theme of all of this is I would spend less time focused on the cash flow issues and more time focused on what the overall incentives are and who has leverage in the varying bargaining relationships that occur across the different steps in my chart. So the next slide, I think I'm finishing up. Do we have another slide? There we go. I was finishing up. So thank you. As always, it's good to hear Mark and Michael talk, and look forward to your questions.
Great. Thanks, Mike. So thank you all for very thoughtful presentations. So we have some questions we'd like all three of you to speak to, and then hopefully we'll have time, the committee members can then ask some additional questions. So first question is, what do you think the vision should be for structuring the payment methodology of future population-based total cost of care models? Now, some of this you addressed in your presentations, but any specific comments would be helpful. So I'll start with Mark.
I mean, I think I did talk about this in my layout. The one other thing I would add to that, which I don't know if there's been a lot, either in my comments or, actually, I want to say something else. I appreciate the fact that Mike McWilliams said, I agree with Mark, but I also want to point out here, my views of all of this have been shaped by the two Mikes. So I think the causation is reversed here, just so everybody follows here. So my principles, I think I addressed some of what you're asking here. One area that I didn't speak to, and I'm not sure there was a lot of discussion around it, is how the beneficiary is involved. And I think the benefit, and this is kind of off on a different track, so I'll be very short and move on to, you can move on to other people. I think beneficiaries should select either a primary care physician or a physician who is their primary contact. If you have a heart condition, it might be a cardiologist. And that should be a point where the beneficiary is engaged in, the process of care, and that allows the primary care physician or primary contact to engage in a greater level of steering. And that's one thing I'm not sure anybody spoke to, including myself, and it's a view that I have. But with that, I'll stop and let you go on.
Thanks, Mark. Michael McWilliams, again, you certainly have touched on some of this in your presentation, but any further thoughts around structuring payment methodology for total cost of care models?
Sure. Thanks, Paul. So I first want to just pick up on that thread that Mark just laid down, and because I agree, and it was sort of one of the bullets in my very last slide. I think we need to be thinking about how to cut beneficiaries in on the savings more explicitly. There's a mechanism for doing that in MA, but not as much in the ACO models. And that seems to be feasible, although it's complicated, but perhaps some at least premium buy downs, having a cut of the savings go to that so that beneficiaries actually are drawn to more efficient providers and actually can tangibly feel the benefits of a new payment system. And then sort of stepping back, I think, these models are focused on the traditional Medicare program. So there is this sort of meta question about where thinking in long-term vision for these models, we need a long-term vision for the Medicare program. Medicare Advantage is expanding rapidly, traditional Medicare shrinking rapidly. So I think we do need to think about how we're going to structure the Medicare program writ large if we're going to be thinking about the long-run vision for APMs and ACOs. Assuming that we continue to have a viable traditional Medicare program, I think there is emerging consensus that an ACO-like payment system as a foundation makes sense, with then some bundles or episodes underneath it to some extent. I think both Mark and I touched on how that foundation should be sort of multi-track to accommodate more providers. I think even in steady state, we want to make sure that entry is pretty easy and there's sort of low risk for innovation. And then finally, we probably need to be thinking more about participation incentives. So far, we have focused on carrots. There are really very few sticks. There is sort of slow growth in scheduled fee increases, which makes fee-for-service less appealing. But other than that, not a whole lot of reason for many providers to join, other than being able to gain from efficiency, which hopefully will emerge as we redesign benchmarks. But one thing that does play into participation incentives that I wanted to mention is that we're probably not going to get very far if we keep taking every new service and attaching a code to it and putting it in the fee schedule. Because a major advantage of these new payment models is to give providers the flexibility to innovate in care delivery and do things off the fee schedule and offer that to beneficiaries, and to do so without revenue losses. And so if we keep putting it in the fee schedules, then we just keep allowing fee-for-service to support that care and also risk running up spending.
Great. Thanks, Michael. Mike?
Yeah, Steve, that's such a huge question. I think our paper's probably 25 pages and reads like 100, the Brookings one. I will say I'm speaking in my capacity as a professor, but I would refer people to the MedPAC chapter where some versions of this are outlined, particularly the foundational ACO model. Let me say a few quick things in response to your question. The first thing, and there's a JAMA Health Forum piece, I think it was, where I outlined this view. I think we need to move away from a test and diffuse mentality where we're constantly creating models, evaluating models, relaunching models, creating other models without the acknowledgement that they all, can conflict with each other. So one test of a model that works might not work if you launch it in the context of a whole bunch of other models. So in there I said, it's fine to let a thousand flowers bloom, don't plant them all in the same hole. So I think we need to move away from that type of thinking towards a foundational type model. You've got three people here that basically agree that a population-based model foundation works with episodes added on top of that in varying ways. So I won't go delve into that. The only other thing I'll emphasize, because Michael's little graphics went by so quickly, that was like, in my mind, we should just spend time on this issue of administrative benchmarks. But I think it's important to understand that the delivery system, in my opinion, needs some sense of direction. And for my taste, and I understand this is just me, some sense of budget and responsibility for managing economic and clinical outcomes. And administrative benchmarks do that in a way that don't involve ratcheting the money away if they're successful and give them a target in advance. So unlike a lot of these retrospective models where you wait until after the performance period and then someone tells you what your benchmarks was, an administrative benchmark says to an organization, you get 3% more each year. There's a ton of implementation issues. I think there's a lot more work that needs to be done here. So I don't mean to discuss it so glibly, but I think in my mind we would move towards a more budgeted system, and administrative benchmarks are a way of doing that, and hopefully we can talk more about that. The last thing I'll say in this spirit, and I won't call this my vision, I'll call it my concern, is we cannot have an APM landscape if we have 80% of people in Medicare Advantage. So I don't consider Medicare Advantage policy central to how we design APMs in a technical sense, but it might be the most important thing to the future of alternative payment models. So if you ask me one thing I could do to support alternative, actually I'd say two things, because I'm not good at stopping one. Two things. Thing number one is I would reform, that's code for cut, how we pay Medicare Advantage. And two, I would build better alternative payment models along the way as we've been discussing. But don't think that you can build the perfect alternative payment models. If MA is so much more lucrative than in fee-for-service, it will swallow whatever you can do on the alternative payment model side.
Great. Thanks, Mike.
Part of your purview.
Yeah, thank you. Before we move to the next question, I just want to get a sense of how many committee members have questions. If they could just turn there. Just so I manage the time, okay, for the moment. Okay. So just moving again to the next question, and again, a lot of this has been addressed in your presentations, but really looking for additional thoughts that you may have. In thinking about the kinds of payment model design features and financial incentives that are most important, So what do you think are the most important features? And then can you point to any evidence regarding the effectiveness of these approaches? So starting with Michael McWilliams.
Sure. So I think my number one on this list would be reform of the way that benchmarks are set, as we've all been alluding to. And wish I could have gone through those slides in a little bit more detail, but the sort of bottom line there, as Mike was just describing, is that if we eliminate these ratchet effects, the incentives get much, much stronger to save and therefore much, much stronger to participate. And it gives everyone a chance to prosper by providing more efficient care, and gives everyone a chance to do better than they would in fee-for-service. And that's just not the case under benchmarking policy to date. So that would be my number one. I also think that we shouldn't be so afraid to increase savings rates. I think the pushback against that is that Medicare doesn't get a cut of the savings, but if we successfully move to a new payment system with an externally set benchmarks, then the program has an opportunity to set spending growth according to a rate that we desire. And that may be in the long run how Medicare can control spending, as opposed to partial savings along the way. So I'll stop there, because I think we haven't talked about episodes, and there's a lot of thorny issues that arise with how to integrate them that speak to sort of features of models, I suppose. But I'll stop there.
Thanks, Michael. Mike?
Yeah, so my number one is also benchmarks. My number two is risk adjustment. None of this works if you can't. There's a lot of issues with risk adjustment and coding, although I have to tell you, I think the status quo does much better in the ACO program, not the MA program, but in the ACO program. I think the status quo is much better on risk adjustment than it does on benchmark setting, but risk adjustment will be number two. Number three is attribution. Mark mentioned how people pick primary care providers. I think we need to, one of the big challenges for this whole system of alternative payment models is, unlike the Medicare Advantage program where you know who's enrolled because they've enrolled, these APMs don't. Different people have different views about how problematic those things are. But those are the sort of the three most important parameters of the design. I will say, overarching beyond all that is some vision for how they're all going to fit together. So the right way to think through this, or at least the way I think through it, I won't call it the right way. The right way I think through this is there's certain care that we want not delivered. Mark mentioned low value care. We want high value care delivered, low value care not delivered, just to simplify. And the question is, when the low value care is eliminated, who gets to keep the savings? And the system of APMs that you set up determine that. So if you set up a broad population-based ACO and you avoid an unnecessary admission to a SNF or an unnecessary MRI, those savings, the bonus, typically goes to the organization that employs the primary care doctor. If you set up a episode-based payment model where that MRI or SNF admission is part of the episode, the savings go to whoever you've assigned the episode to. And you want to make sure that when you set these up, that you give the savings to the organizations that are most likely to get this, to realize the savings. But in doing so, you have to make sure that you don't siphon off all the low-hanging fruit that makes no one want to take on the broad population-based risk. And that's the core tension in how these are designed. And I think you're just need some work to figure out how that plays out. And how you add those episodes in. The last piece I'll say, I make it last not because it's not as important. It might be in some ways the most important. It just scares me the most is whether the participation is voluntary or mandatory. If you're in a voluntary model, the model design gets very constrained by getting people to participate. And a mandatory model, or I don't even say mandatory, a heavily incented model, you have much more flexibility in how you set up these models. And so the problem with that, of course, is not all providers can succeed if they're mandated in. I don't see a lot of mandatory models, broad mandatory models in our future. but how we think through that ends up, I think, being important for how this whole ecosystem of models will work together.
Great. Thanks. And Mark?
Yeah, of course, everything got said for the most part, but I'll just quickly hit a couple of points. I completely agree on the benchmarks, and I think having them set, and if you can make sure that the programs portion of the savings are set and then grant, if people are accepting risks, they should be granted much greater flexibility underneath that. I understand the notion that a fee-for-service system with a reconciliation at the end can perform very much like, a capitated system, but I also think that there should be some certainty in cash flow during the course of the year so that you know where you stand. I think the surprise at the end of the year is very tough for people to deal with. Other people have said this, but I'll just restate it. We're all talking about these APMs and ACOs and all the rest of it, but you have to go after fee-for-service and manage care around it. Otherwise, you just get arbitraging between different systems. And then finally, I thought the innovative thing I was going to say was to speak to the mandatory nature of models. I do think we should move more towards mandatory models, but of course, Mike scooped me on that, and so I don't have anything left to add.
Thanks, Mark. So one of the themes throughout our series of meetings this year, we've been grappling with the fact that providers are in different stages of readiness to move toward value-based care. So in your view, what are the most important interim steps for increasing provider participation in value-based care models, helping providers assume greater levels of financial risk, and encouraging investments in care delivery transformation? Mike Chernew, I'll start with you.
I'm glad that's the one I get to go first on. Certainty about what the models are going to be like. I think it is really impossible to get providers to commit to doing all of this for a 2 or 3 year model where you're going to be told the benchmark after the end and you don't know how the next model is going to be layered on. I just think if you could just tell providers, in my opinion, where things are going, I think they can begin to change their business models and manage around that. Now, of course, MA becomes confusing. They don't know how many patients will be in these models, so there's a lot of confusion. But basically, big picture, some certainty about where the system's going to look like and what payment models are going to look like going forward, I think is by far the most important thing. Within that certainty should be certainty. For example, there's no ratchet. If you tell a provider, come along and really try and become more efficient, but by the way, in 3 years, we're going to rebase you down so you're back at square one in 3 years. That's not a very appealing process. And so I just don't think we should be afraid of providers prospering in these models. If the providers can prosper in these models, but we can have top line spending growth going at 4% and not 5% or 3% and not 5%, you pick your number. If we can get top line spending growth at a sustainable rate and providers can prosper underneath that by becoming more efficient, I think that's a win-win for everybody. And I think there's too much concern about as soon as providers seem to be doing well, we're going to take it all away because the program needs that money. I think the basic game here is providers need to profit from improving efficiency, and at least in the Medicare program, that will help sustain them through a future of very flat fee increases.
Great. Thanks, Mike. Mark?
I'm going to let this one go by. I think a lot of what I've said's been said, so I'll let this go to Mike.
Okay. And then Michael?
Yeah, I don't have much to add either. Completely agree with Mike that any interim step needs to be explicitly linked to where we're going in the long term in order for it to be an effective interim step. And we'll say, though, that there have been some interim steps recently taken that I mentioned in the ACO REACH model and the proposed rule in the shared savings program. Those include setting benchmarks higher for providers disproportionately serving underserved populations. That not only helps address a resource disparity, but creates an incentive to attract those populations with enhanced care. There is in the shared savings program proposed rule, beginning of movement towards an external benchmark update called the Accountable Care Perspective Trend that's proposed to be blended in the benchmarking. Other measures to sort of limit the ratcheting effects and sort of slow convergence of benchmarks to make sure the program remains attractive to providers with high spending. They're the ones that have the most savings potential. So all those steps, I think, are important ones. And again, coming back to benchmarks, as long as they create opportunities, as Mike said, to prosper from providing more efficient care under spending growth that we can live with, then that should draw more providers into the program and create an incentive for investments from other sources as well. And then, of course, there's still a lot of work to do the primary care capitation, risk adjustment, mitigating coding incentives, figuring out how to cut beneficiaries in the savings. And then I think the last thing we haven't touched on is multi-payer alignment, which is very hard. But I do think that we underestimate the importance of getting this right in Medicare. If we can get it right in Medicare, then we increase our chances of getting it right in Medicaid programs, increase our chances of leveraging federal dollars, which amount to over half of the insured in this country, to get federally covered or subsidized insurers on board with the same sound design. And then I think it's much easier to hit a tipping point with the commercial insurers.
Great. Thanks, Michael. So the final question for the three of you before we open it up to the committee members, just simply, are there any additional insights you'd like to share about developing effective payment methodologies for population-based models? Mark, I'll start with you.
Sorry. No, I'm just going to stand.
Okay. Michael McWilliams?
Yeah, I'll hold as well.
Okay.
So now it's all on me, so I'll be quick.
Yeah.
I've heard a lot of debate lately about things like Medicare Advantage for all. So there is a lot of value in my mind that you can get from Medicare Advantage plans. But if we're going to think about that, we need to really think about the design of Medicare Advantage, because it was never designed to be as big as it is now. And so I don't know if you consider Medicare Advantage an alternative payment model, but in some of the prep calls, it seemed like it might be. And if that's true, we really need to think about what we want through a Medicare Advantage type system, and how we want to leverage any efficiencies that the plans can gain. Because I mentioned they do have the ability to gain some efficiencies and improve value. It's just we don't have a system that's well designed to pay them. They rely on the fee-for-service benchmarks.
Great. Thanks, Mike. So we do have some time, so I'm going to turn to our PTAC members for questions. So, Bruce?
Thanks. Hi, guys. Thank you very much. That's good stuff. Each of you had some interesting things to say about fee-for-service. Mark Miller said one of the principles is make fee-for-service less profitable. Mike Chernow said that concern with the fee-for-service chassis is a bit of a red herring. And I think Mike McWilliams said if we continue to rely on fee schedules for payment to providers, we're not going to get very far, if I got that right. So my question is, what do you think is the role of fee-for-service? Should we discourage providers from continuing to use it, even if they're in Medicare Advantage plans, for example? Can we do away with it? Should we try to do away with it? What do you think?
If I could just say briefly, I believe we're going to need a fee-for-service system. It sets the scoring for my colleague, actually Michael's colleague as well, Bruce Landon, wrote something. If you avoid an MRI, how much do you save? Fee-for-service sets the scoring there. So I believe we need, as Mark said, we need to continue to reform aspects of fee-for-service. I don't think we can get rid of it. I would devote probably mildly less attention to some of the underlying details. There's certain things site neutral I think we need to fix. So I think we need to pay attention to fee for service because of the underlying scoring system, but I don't think we should discourage it from existing. I think we're going to need it in an APM world. I think if an organization wants to use it in varying levels of the steps, I think that's fine. I think if we can get the top line right, we should let the part below that work out as it can. And in Medicare, we should continue to try and reform it. If you all know Bob Berenson, I think he used to be on PTAC, I'm not sure. You should have him come talk about how to reform fee-for-service. But I do think it needs to exist.
I would agree with that set of comments. I think fee-for-service should be uncomfortable. I also thought Mike Chernow's point was that if you're paying on fee-for-service, but you have an incentive structure that sits over it, you don't have to worry as much, and I subscribe to that. But I do think the fee-for-service system should exist. I think it should be less profitable than moving to a better managed system. And I also think that there are distortions in the underlying fee-for-service structure in Medicare that should be corrected, between what we pay for primary care or cognitive specialties versus procedural specialties. And then, as I said, I kind of think the way we pay primary care on a visit-by-visit basis is not the way to approach that. So, no, I would not eliminate it. And I think it is the reference point, as Mike Chernow said, but would not eliminate it, just make it uncomfortable.
Yeah, and I would agree with all those comments as well. And I think it's good to distinguish sort of fee-for-service writ large as a payment system and fee-for-service for keeping track and for paying sort of below a level of a risk-bearing organization, whether it's a plan or provider organization. And I think this goes to sort of Mike's description of all the different levels in the system and what I touched on with group versus individual level incentives. In many cases, it may make a lot of sense for internal compensation to pay on a fee-for-service basis for certain services. And also, it may make sense, at least in some markets, for there to be risk-bearing organizations responsible for the total cost of care. But the way they transmit those incentives are to the rest of the market is by demanding efficiency and from specialists or hospitals, downstream providers who may be paid on a fee-for-service basis. But if the market is competitive and there's enough ACOs, a new payment system broadens, then there'll be a sufficient demand for efficiency such that even fee-for-service pay providers have an incentive to be more efficient.
Thanks, Michael. Larry?
Actually, Bruce asked the question that I was going to ask, but on the basis of the answers that we just heard, I'd like to force our three speakers into a little bit more granularity. There are specialties, the one that I was raised in, gastroenterology, where 70% of the revenue of a GI practice comes from one procedure that's performed on an elective basis. And yet, where we need their performance in disease management for complex diseases, they are markedly undercompensated. So tell us, how do we get to where you want to get to using a fee-for-service backbone? How do we make it unappealing? What would be the steps?
Mark, I'm going to have you start since you mentioned about fee-for-service making it uncomfortable. So thoughts about?
Yeah, and I'm pretty sure the mics are going to be able to do a better job here. But the point that I think, the mics and myself have been saying is that there were terms used that you want to allow for innovation inside, let's call it an accountable care model. So while revenue may flow to the model through the fee-for-service, payment structure, it doesn't have to be in the end after you reallocate based on performance, it doesn't have to all be paid exactly the way it would have been paid under fee-for-service. This is what I meant by flexibility, particularly as the organization begins to accept risk. It should be allowed a flexibility in order to provide incentives to individual providers who are in the system. And so I would see the answer to your question being that the compensation for that kind of consultation would be adjusted in a way that would be attractive and supportive to that particular provider.
Michael McWilliams?
Sure. No, I think this is really sort of, it's a good question and sort of digging into all the various ways that the incentives can be or should be transmitted. I tend to think of this sort of two models in mind. One, an organization model that employs the gastroenterologist, in which case you're talking about internal compensation. The ownership model, while it hasn't been shown to necessarily improve quality, it does simplify some things by having employment relationships in place, and there can be sort of direct managerial control of practice. We have historically not really done a good job in the medical profession of developing management techniques to manage physicians to generate what we care about, which is better patient care and patient experiences. To me, that is sort of the major challenge ahead of us for quality. But certainly one can imagine salarying a specialist from an internal compensation standpoint, and then using various management strategies to non-financial incentives, different practice environments, et cetera, to encourage the physician to practice as is in the best interest of society, or at least for patients, and with the risk-bearing organizations more efficiently. It gets a little trickier when that specialist is not under an employment relationship, and this is sort of within a sort of affiliated network or even just an unaffiliated referral. Clearly, there are opportunities for subcontracting that can look like a fee-for-service, but with an agreement that, hey, we want to refer to a group that doesn't scope everyone, and for that, we'll pay you an additional care management fee as well, so that you have the additional costs of better communication covered. It could be a population-based payment sort of subcontract where it's just a fixed payment for the organization's or practice's population. And that's basically sort of carving out the GI services for that population in a subcontract. There have been various conversations about whether what's the extent to which a payer like Medicare should step in and write that subcontract as an episode. But I generally, and then you could have a model, as I said before, where the fee-for-service model works okay because there's just a competitive enough market that ACOs are going to refer to the more efficient, higher quality gastroenterologists. And, to some extent, the savings do need to come from somewhere, and we probably, and we know we provide too much care. It's certainly not in primary care, so there will be reduced income in certain specialties. So I'll stop there, but I think it's sort of, there's no one right answer, but the key is having that foundation, that population-based payment model foundation in place to then allow that sort of flexibility for the incentives to flow both through financial and non-financial means.
Thanks, Michael. Mike?
Yeah, so to the extent that your question implies that Medicare or others should do a better job on setting the relative fees across the thousands of fees that exist, I agree. And again, that's probably a Bob Berenson comment. It might be involved into a discussion of the RUC, which I'd rather not have. It certainly evolves into a discussion of site-neutral payment and a bunch of other things like that. And we have an existing process for setting fees. It's unbelievably cumbersome in a variety of ways, and we tend to want to add more codes, and we get challenged by all this new virtual care about how we're going to set up the fees. That process should continue. The stakes of getting all of that right, or the harm of getting all of that wrong, in my view, is dampened when varying levels of payment or organization in the steps that I gave can transform that. So if we can hold a Medicare Advantage plan to making sure that they've recruited enough gastroenterologists and that they're providing the services that are needed and high value and not the services that are not needed and low value, the actual flow to the gastroenterologist or their practice is less so. And certainly, you don't want to be in a situation where you tell a provider organization that doing something is very profitable and then you utilization review them away from actually doing it. So you don't want to step on the gas and the brake at the same time. But in the grand, so we should devote our time to getting those relative fees right. I just think in the existing fee-for-service system, we will never manage that right as technology changes and a whole bunch of other things change. So as long as you have some overarching, and I agree with Mark's characterization of what I said, as long as you have some overarching system that can manage care, change the referrals, change compensation, maybe in an employment relationship, maybe in a bonus relationship, maybe in a quality payment system relationship, I won't presume to know. You just have to worry less about the fact that inevitably you're going to get these payment rates wrong and you're not going to be able to risk adjust them in things, and they're going to bump into each other. So I think we have to keep trying and just accept that we're only going to get so far in getting it right.
Thanks, Mike. Appreciate all those comments and appreciate the reference to Bob Berenson, who I think Bruce and I can remember probably at the first meeting he made that comment. We're going to start looking at models, but, we can do a lot with the fee schedule to align incentives. Jenny, did you have a?
Going back to, I love the slide Mike Chernow has with incentives can vary by step, because I think it really illustrates that flow of funds that's so fundamental to the system. But one of the things that we're seeing is, with the advent of ACOs, all of a sudden hospital groups started employing a lot of primary care physicians, right? It shifted the demographics of employment. Medicare Advantage gave rise to payviders, and all of a sudden payers started having huge offsprings of primary care provider groups. All of that lent itself to not necessarily having some of the flourishing of primary care and providers that I think, Mike, you're advocating for. And so how would you think about, as adoption of Medicare Advantage grows, having engendering a certain system that can provide for independence of attribution, but also function within the Medicare Advantage system?
As you probably know, I'd love to answer. In this case, I don't understand the question.
Well, here payers are often controlling Medicare Advantage attribution, right? They get enrollees and then it's attributed to payer groups. But if you think about with the advent of payviders, a lot of times that is consolidated in certain geographies and there isn't the choice. And then physicians, primary care physicians, oftentimes have to join entities that then can get this patient attribution in order to participate in a capitated plan. How would you change that attribution model in order to encourage independence?
I might be more ambivalent on independence than you are. I'm supportive of independence. I think if you look at the work that, say, we've done, Michael and I have done, others have done, the independence of the physicians, the primary care physicians from the hospital helps you. My joke, I wish I could see you all. I can't tell. My jokes are bad. It's hard to keep people out of the hospital if you're a hospital. So I think there's some merit and there's a lot of concern and consolidation on the commercial prices side, which seems a little bit out of scope for this conversation. But I think the short answer to your question is and Mark said this, we need to reform primary care payments for a bunch of reasons. The one that motivates me, quite honestly, is we have no idea how to pay for all this virtual care. We have no idea how to pay for all these e-messages and portal messages. I was talking to a large group of primary care physician groups, so a bunch of America's Physician Groups, I think is what they're called, earlier last week. And, you could debate 2 or 3% updates or what's going on in MACRA, and MACRA is a whole separate issue. But the real problem is the burden on primary care practitioners to practice independently and all the various things they have to do makes it really hard to be an independent primary care provider. I don't think that's a fee schedule issue, honestly. I think that's an administrative burden issue of all the things that are going on with primary care and all the various things we make them do. It wouldn't bother me if they were in bigger systems, honestly, if I could control the prices of these big systems. I think there's going to be a lot of support for that integration. It's just you need to cap the top amount of money, because if you don't and they're owned by hospitals, they'll save less money if they're independent than they can do it through the referrals. So I don't know. We're getting close to time here. How we should do that is really challenging, but I do think we have to rethink the unit of service of what primary care means, because fee-for-service does a horrible job of creating the incentives for the unit of service that primary care practitioners provide. And so that requires, Mark said this, reforming the way primary care is paid, independent of what overarching system you lay on top, which we've been talking about today.
Great. Other comments, either Michael or Mark?
I think I may understand where maybe I'll try to rephrase this. I think that maybe the concern is that primary care providers may be shifting to working with payviders that exclusively take care of Medicare Advantage enrollees, which may be fostering consolidation. So insofar as that's the concern, I think that this sort of like notion of MA poaching doctors, poaching patients has certainly been expressed. I haven't seen really rigorous evidence on the extent to which this has happened, but I will say that just taking a step back and sort of echoing some of the comments that we made earlier, there's sort of two prongs of the consideration here. One is sort of MA payments, so we're subsidizing MA. So clearly, to the extent that this is happening because a PCP can get paid 20% more if they go work for an MA payvider, they're going to do that. And on the one hand, it's good that MA is funneling more resources down to primary care, but it's not entirely clear from a programmatic standpoint that we want to be subsidizing MA to the extent that we are. And then similarly, this is sort of the motivation for addressing the primary care spending within ACO models, or total cost of care models. We have an opportunity. It's far simpler to do that if we capitate or provide a global payment for primary care within an ACO model that basically then allows us to set benchmarks or advanced payments for primary care that are more easily dialed up, and so that can help sort of balance out primary care reimbursement. And then across the board, I think there is consensus that we probably want to increase spending on primary care. But again, it's that imbalance between sort of how we're paying MA and how we pay in traditional Medicare that may be leading to any sort of trend that you may have been referring to.
And that's the only thing I'll add is, early, and I think everybody said this in one form or another, and I said you have to pay attention to fee-for-service and managed care and how it bumps into these particular models. On the fee-for-service side, I would go to a PMPM type of arrangement for primary care. And then just what Michael said on MA, if you overpay and you subsidize MA, then they're going to be poaching and you're going to get these kinds of impacts on the system.
Thank you. Just one last question, Jennifer.
Thanks to our three speakers for a wonderful conversation. Each of you has commented that voluntary participation in these models is problematic. So I want to give you an opportunity to decide if your recommendation around ideal features for a model are either mandatory or heavily incented, or does it not matter?
Mike Chernow, I'll let you start.
I start too much. In our white paper, we basically had this feature varying by track. So the gist of it is, for large organizations, I think they should be heavily incented, and they should be heavily incented to incorporate two-sided risk in a range, sort of heavily incented in very strong models. For small independent physician groups, I actually think if you get rid of the rats and do a bunch of other things, you can be fine with what I'll call MSSP Classic. I'll stop there. If it's unclear, Mike McWilliams will clarify.
All right, Michael, I'll let you go next.
Yeah, I think that's right. I think, first of all, sometimes we sort of dichotomize this distinction between voluntary and mandatory when really it's just a spectrum of participation incentives. And in any sort of quote unquote mandatory model, it's never really mandatory. There's just sort of whatever penalties or costs of not participating. It may be so extreme as to not get paid. So I think we should be thinking about it as a spectrum. And as Mike just said, and this is sort of the main point we make in our white paper, where on the spectrum is needed to get different types of providers in differs. And so we should be thinking, we should have that in mind when we devise complementary payment policies that make these models more or less attractive.
Mark, you get the last word.
Okay. I agree. I tend towards heavily incented and even moving into mandatory. And by heavily incented, for example, again, both on the fee-for-service side as a push and as on the alternative model side as a pull. And I also think, and there's way too little time to discuss this, there are circumstances we should consider for mandatory, because something Mike McWilliams said way early on in the conversation is it's getting harder and harder to study effects. And to the extent that you can have some mandatory elements to this in order to get the research results you're looking for, I would push in that direction. But they were way over time, and I blame both the Mikes for that.
Well, with that, I'd like to thank all of you for joining us this morning. You helped us cover a lot of ground during the session. You're certainly welcome to stay and listen as our meeting continues. But at this time, we have a break until 11:25 Eastern Time. So please join us then. We have a great lineup of guests for our second listening session of the day. Thanks again.
Produced by the U.S. Department of Health and Human Services.